Hello. Yeah, okay. Good afternoon, everyone. A very warm welcome to all of you to this instruction course titled Structured Phaco Training, a Burning Need. I'm Dr. Niloufar Said Mohammed, and it's my privilege to be the chief instructor for this session. I have with me Dr. Jyoti Anup, co-instructor. Before we start off this session, we have a talk by Dr. Ellen Kumaran Pashupati he's a medical director of Navashakti Netralaya, Bangalore. Sir, please come. He is the president of Bangalore Ophthalmic Society and treasurer of Karnataka Ophthalmic Society and joint treasurer of AIOS. He'll be giving a trade talk by Appaswamy titled Dry Eye. Over to you, sir.
Thank you, Dr. Niloufar, and thank you for accommodating. Sorry for the delay. My flight got cancelled and I had to probably travel to both sides of India and then come here from Bangalore, Chennai, and then here. That's how this talk was delayed. That's the talk for the day. This is I think Appaswamy has asked me to present this, and they've asked your people also. All of us know that tear film has 3 layers, and the most common type of dry eye is evaporative dry eye. All of us know this, so let's not get into this. All of us also know that the treatment for dry eyes, of course, started with artificial tears, but then you can see this inside ring. All these have to be treated. Broadly, that can be classified into 3 different types. One, meibomian gland disease, other, infections, and third, lid disorders. Along with this, inflammation has to be treated and lubricants has to be given. But then, what if we can provide all these 3 in one? That's where comes the role of IPL or IRPL. We are going to talk about IRPL. I'll tell you what is the difference between IPL and IRPL later. But then for the time being, IPL, it was an incidental discovery, very accidental discovery, wherein this IPL was used by dermatologists, and Rolando Toyos found that when IPL was used on the face, even the dry eye symptoms decreased. That's how we accidentally found out that this is being used. Now, what is IPL? Starts from around, it's a light therapy, that's all. Starts from around 380 nanometers till around 1200 nanometers of light was used on the skin. This was meant predominantly for the skin. That is what it was used. How IRPL is different, we'll come to it later. But what we can see here, the lesser the wavelength, it can penetrate only probably 1 millimeter into the thing. Dermis, probably a little bit of subdermis. But then larger wavelength is the one that goes below and does the action. What are the actions? Again, we'll have a look at it later. That's where we started. It was in cases of rosacea and other skin lesions. Dry eye was being treated, and he found out that this works also for dry eye. That is the machine. Only thing what I want to talk about, this is an IRPL machine. Any machine that delivers IPL is intense pulse light, IRPL is intense regulated pulse light. Anything that gives this light has a power supply, a capacitor, and a cooling system. The advantage, one of the advantages of this IRPL, it's a patented cooling system, cools faster, safer for the patient, and then there is a handpiece, just like how our Phaco handpiece is, there is a handpiece which delivers the light pulses. What are the mechanisms of action? Lot of mechanisms have been spoken about. All these are the mechanism of action. We'll get into it in detail. Most important, and the first thing that was found to have the telangiectatic blood vessels, that is abnormal blood vessels on the skin. It causes shrinkage by causing coagulation. That's the first thing. How does this help? If blood supply is reduced, inflammation is reduced. Hence, all these inflammatory mediators in the tears have been noted to be reduced. Second, this is the most important what is being studied now. There's one more important than this. This is one of the most important is photomodulation. What does photomodulation do? Any light, particularly in the red wavelength, remember this red wavelength, that is a larger wavelength. Why I am specifying this, we'll come to it again later. Photomodulation, with the help of particularly red and near infrared light, stimulates, excites the cytochrome C oxidase. This helps in a chain reaction which increases the intracellular free calcium concentration, so it stimulates the physiological process in the cell. Something like this, all these alternative naturotherapy without using things, that's something like that, but this is proven in science. Now, what does this photomodulation do? Number one, increases the collagen synthesis. This is proven. So remodeling happens. That's why they were using this on the skin, on the dermis. Number 2, reduces the epithelial cell turnover. How does this help? Remember, all these lacrimal glands, all the meibomian glands are holocrine glands. What do we mean by holocrine? Entire cell is secreted as a secretion, as a meibum. So, if it reduces the epithelial turnover, there is less reduction of this excretion of the cells. So, how does this help? Clogging is reduced. Again, this is an action of photobiomodulation. Also, the light radiation decreases the reactive oxygen species levels. Now, we know that this reactive oxidation species increases inflammation. So, on the inflammation, there are two types of benefit this IRPL or IPL gives. Number 1, it upregulates the good interleukins, interleukin 10, TGF beta, what you see here, upregulates, they reduce the inflammation. And also, it downregulates the inflammatory mediators, IL-6 particularly and TNF alpha. Now, this indirectly causes decreased matrix metalloproteinases, which is again reduces the inflammation. So, it plays on the inflammation. This is a very proven thing. Demodex, bacterial infections reduce because this intense pulse light is absorbed by the outer shell of the bacteria and Demodex, and they die. One thing which is questioned, of course, when it came out first, what was told was the temperature increase, thereby oil is liquefied and it is thrown out, but then that is questioned nowadays. All these, it's proven, reduces inflammation. All these actions reduces inflammation. So, single thing to tackle all this, the vicious cycle is cut down by the use of IRPL or IPL. But what is more important is happening with IRPL, and why it's happening is what I'm going to show now. All of us know that there is another cycle here. The sensory nerves carry the sensory information and thereby makes you blink. Now that is also affected by light, not only IRPL, by any light. So sensory part is over. What happens to the autonomic nervous system? We know there is parasympathetic activity and sympathetic activity. Parasympathetic, it normally rest, coolness. Sympathetic, usually fight or flight attitude. They have to be balanced. And which of these two is important for the eye? Well, look at this. These are the receptors in the eye. 6 receptors, of which 4 are directly related to parasympathetic pathway. So parasympathetic pathway is probably more important. This is a study that was done last 2 minutes. I'll finish it off. Sorry. This study again proved parasympathetic pathway is more important, and clinically all of us know pilocarpine has been used for Sjogren's disease. So I'm not getting into this. This is the afferent pathway, how this nerve goes, but what I would like to concentrate is this particular thing. Transnasal stimulation of the nasal mucosa, increase the tear production. This has been proven, and these are the 3 methods, and this is the meta-analysis that is found in the article. You can find out that TNS helps, and the same logic is being used in IRPL in stimulating these branches of the lacrimal nerves, which carry both the sensory as well as the efferent pathway. How does this happen? Because of this light, there is microgradient change in the temperature that stimulates the nerves, releases the neurotransmitters which help. And how does IRPL help? Because there is a differential pulses that is there when compared to an IPL. These two are the short wave pulses, 2 short wave broad pulses, 6 large wave. Those are the things that penetrate and cause this parasympathetic increase. How do we use it? This is the Fitzpatrick scale. Indians normally come 2 to 4 or 5, in South Indians 5 probably. This has been specified till from 1 to 4. And 5 studies have happened. I have used in some types of 6 also. There has been no problem. That is the advantage with using an IRPL. IPL you cannot use. IRPL has been graded for the tissues. This is how you use it. 5 shots per eye in this direction. In that area, I have shown why it is. Session 1 on 0 day, 15 days, 45 days, 75 days. And with this treatment, the patient is free from problems for at least 6 months to 3 years depending on what type is. Again, they have a very good setup. I'm not getting into it due to lack of time because that's not the topic. Scientists, we need to prove it, right? That's another meta-analysis which said only around 7% had problems. The rest of them were all normal. Where do we use it? Stage 2 and beyond. Thank you for the opportunity. Sorry for the little bit delay. And thank you, Dr. Nilofer, again for accommodating.
Thank you, sir, so much for your talk.
Oh, sorry, I thought it's my laptop and I disconnected it. Please.
Okay, so coming back to our topic, structured phaco training, a burning need. As we all know, many young ophthalmologists face limited exposure to cataract surgery during their training, and our goal today is to address that gap. In this session, we will share practical approaches and structured methods to help every surgeon transition smoothly and safely from wet lab training to basic cataract surgery to phaco without compromising on surgical quality or patient safety. Our first talk today is by Dr. Shobha Sarah Matthew, who will be speaking on Practice Makes Perfect, Role of a Wet Lab. Dr. Shobha is a highly skilled cataract surgeon with cornea fellowship from Singapore National Eye Center. Her insights today will highlight how the wet lab serves as a perfect bridge between theory and real-world surgery. Dr. Shobha, over to you.
Thank you, Dr. Nilofer, for this opportunity to talk. So, the role of wet lab, it is a very important topic which we cannot replace with anything else. So, when it comes to ophthalmology, we are dealing with 10-0 nylons and micro instruments, and the size of the instruments all changes. So, what is the role of wet lab in ophthalmology? Before we are going to do surgery in a patient, in a live patient, we have to do our homework first. That is where the wet lab comes. It is a risk-free environment, and it will make the trainees to familiarize with the microscope, with the hand-eye coordination and everything. And we have to refine the surgical step, and it is a bridge to live surgery. So, setting up a wet lab, it is also very important. According to studies, it requires a room which will accommodate one trainee and a trainer, and a microscope, operating microscope, and the ophthalmic surgical instruments, and the eyes, even human cadaver eyes or animal. We can use either sheep eye, goat eye, or the pig's eyes also, and phaco machine refurbished. So, this setting up a wet lab in all the training institute is very, very important. And it is, even if the eyes are not available, we can always practice some other things also, like suturing and everything. These are the minimum basic requirement instrument for a wet lab session. And suturing, as I told you before, we are suturing with the 10-0 nylons. So, suturing is the first and foremost skill every ophthalmic surgeon should have, to how to hold the needle holder, how to hold the forceps, how to pass the suture, how to tie the suture, and everything, and with how fast you can do under the microscope. These are the skills every ophthalmic surgeon should learn. And also, I am telling you, this is a very key point, because suturing is your life jacket. Because whatever happens, you have to suture it back. So you have to maintain the globe integrity of the patient. So suturing is the first and very important step you have to learn. And you have to suture in the polyurethane foams sheets or the banana peels. Where I worked in Singapore National Eye Center, the trainees, the residents, first year trainees, unless you do the wet lab session, you are not allowed to enter into the operating theater. So you have to suture 100 very good sutures before entering in, and show it to the mentor before entering into the operation theater. Okay, these are the ways you can practice the suturing in ophthalmology. And coming to practicing the steps of surgery. So human cadaver eye is the best model, which is very less available. So we can either use goat's eyes or pig's eyes also is fine. And you have to stabilize the eye. You can either also use the tape also, micropore tape also, and mount secure in place. And these are another stabilizing instrument you can buy. It is available online also. And even in one, coming to the tunnel construction, in one eye you can practice 4 sides of the eye. 4 tunnels you can practice. And before starting with the SICS, trainees has to practice at least 20 cornea scleral tunnels. And also capsulorhexis, even though it is the feel is little different, can definitely practice rhexis in a goat eye. So this is a video of a wet lab training session practicing the tunnel. And also capsulorhexis, usually previously we used to steam the grape, tomato to get the real feel of the capsule, anterior capsule, and practice the capsulorhexis. It can be also done in thin films also, and at least 100 attempts of capsulorhexis should be done. So these are the ways you can practice the capsulorhexis in the films. Also, the practice you have to, I'm going to show you a video where we are doing a SICS in a goat's eye. So just imagine how a surgeon who is doing at least 20 cases in goat's eye like this, SICS, how the person will perform in human eye. If a person can do, if a person can do at least 20 cases of SICS like this in goat's eye, how that person will perform very well in the real live surgeries. So before going to do live surgeries on live patients, surgeries on live patients have to practice the wet lab very carefully and very meticulously, and your skills should improve. Even the cortex wash. And in the end, implantation of a PMMA lens. Also coming to, this is a structured course on Phaco. So before going to Phaco, what all homework we should do actually. So first homework is know the Phaco machine actually, how the Phaco machine works. It has mainly 3 components: foot pedal, console, and handpiece. And what machine you are using, Venturi or peristaltic machine, what is the aspiration, what is the occludability, what is followability, what is surge, how to prevent surge, and how you can navigate everything forward also. And when in SICS, basically our eyes and mind and hand are working. In Phaco, everything should work together, like eye, ear, hand, foot, mind, everything should be open. So regard to eye, the visual microscope, the proper depth perception. Depth perception is more important in Phaco compared to SICS. Ear, auditory, and hand coordination, foot pedal, how to navigate your foot pedal. At least actually 2 hours you have to train your foot in the foot pedal, how to navigate from aspiration to irrigation to aspiration to Phaco machine before doing it on live patients. Also, this is a platform, help me see, where AOS has done, where you can practice the simulated Phacos in this machine, where you will get the feel of a live patient. Okay, thank you.
Thank you, Dr. Shobha, for the insightful presentation. Next, I invite Dr. for talking on SICS, a stepping stone to Phaco. Dr. Nilofer is a consultant IC from my Vision Eye Hospitals, Thrissur. Over to Dr. Hello, everyone. In this segment, we will explore how mastering SICS lays the foundation for a perfect transition platform to move into Phaco confidently. So for a beginner surgeon, it's very important how to select the patient. The patient should have a prominent globe. It should not be a deep socket. The cornea should be clear with a healthy endothelium, and the AC should be of normal depth. It should not be a shallow AC. Pupil should be well dilated with intact zonules and an NS2 to 3 type of cataract. Now, coming to the steps of SICS. Okay, so first step would be taking a brittle suture. It helps in fixing the globe during tunnel construction and also provides a counter traction force during nucleus extraction. And then next would be peritomy, where you make a conjunctival flap. Here you can see we are doing a temporal SICS. In temporal SICS, there is less of an against the rule astigmatism drift, which is seen in the cataract population. And also there is more of a working space and there's a better red glow. And you do gentle cautery. And then the main step in SICS is the tunnel construction, which you can say is the heart of the SICS. You create a triplanar sclerocorneal tunnel. The external self-sealing incision, the external scleral incision is made about 1.5 to 2 mm away from the limbus. It can be straight or linear or frown shaped, and depth should be 1/3 to half of the scleral thickness, and the length should be 6 to 7 dependent on the density of the nucleus. Then the crescent plate, it makes a gentle, it makes a wriggling movement as you make the tunnel. The tunnel should be of uniform in thickness, and the visibility of the crescent helps in deciding the depth of the tunnel. And as you extend on either side, you should also keep in mind the contour of the globe. When you enter the cornea, the heel should be down. And the next step would be making the side port. And for beginner surgeons, it's always better to stay in the anterior capsule before the capsulotomy. And initial few cases, it's better to start off with can opener technique, where you make multiple punctures on the anterior capsule. It will help them in while doing small pupil cases and also in mature cataract cases later on. Here in this video, we are doing CCC, which is continuous curvilinear capsulorhexis. So after filling the AC with visco, you first create an initial cut is made and the flap is raised. And you fold it over the anterior capsule. And then while you're doing the rhexis, the cystitome is held about like 2 to 3 clock hours away from the shearing force. And the size of the rhexis is very important, at least 5.5 to 6 mm, depending on the density of the nucleus. And it is completed from outside in. Now, after the capsulotomy, again, you have to fill the AC with visco before you make your entry through the main incision, which is the keratome entry. So as you proceed forward, you look for the dimple in the cornea as you enter, and then cut as you enter. And when the plane should be same. You should always be careful about when you're going sideways. Next is the hydrodissection, where you separate the capsule from the cortex by injecting saline. And in the same step, you can do a hydroprolapse also. Here you can see the pole of the nucleus has come out, and you can gently just hook it out with a Sinski hook. And then next step would be nucleus delivery. So you inject visco above and below the nucleus, and here we are using the irrigating vectors method. So it is introduced, and first you engage it into the tunnel, and then only you pull the brittle suture and push the posterior scleral lip and irrigate and take the nucleus out. And the rest of the epinucleus is removed by viscoexpression, and you can also pull the brittle suture. So after this, the cortex aspiration, initially you have to clear the posterior surface of the cornea so you can get a good view. And for the beginners, it's always better to do the aspiration through the side port because the AC will be well formed. And always be aware of the posterior capsule and also the rhexis margin, especially in case of canopera technique, there will be anterior capsular tags. So be careful not to pull it. And when you're going through the main port, make sure to lift the anterior lip. And then again inject visco. The back should be well inflated with visco. And then you take the Sinski and then push the hole through the optic and then drag, depress and dial in a clockwise direction. And then do a thorough cortex visco wash and tap gently on the IOL to remove the visco from below and also through the angles, all of that. So after you have to form the AC. You can see the stretch lines over the posterior capsule that indicates in the back IOL implantation. Then just swipe through the tunnel to make sure there are no nucleus remnants in the tunnel. And the side port is hydrated. Make sure the wound is tight and there is no leak. All right, you can just tap on the dome of the cornea and also on the incision side and make sure there is no leak. All right, and so once you have made sure, if you have any doubt, you have to suture, or else if here there is no leak, so you can just retract the conjunctiva over and just place gentle cautery. So that's about the steps of SICS. Just mentioning few surgical pearls in SICS. As I said, the tunnel construction is the most important step of SICS, and so the visibility of the crescent blade is very important. If it is too superficial, it will be like very clearly visible, and this is how you assess the depth of the tunnel when you're doing the tunnel. If it's too deep, it can lead to premature entry. And then crescent, how you hold the crescent, the heel should be up while you are in sclera, and it should be down while you're entering the cornea. Yeah. And then the rhexis, the size of the rhexis is very important. Depending on the nuclear density, you have to make it bigger, and you have to make sure the flap is folded on top of the anterior capsule while you're doing the rhexis, and it should be always completed from outside in. And before doing keratoderm entry, form the AC with visco, and extension of the entry, you should make sure that the plane is same. And before hydrodissection should not be done in an AC pressurized with visco. Just let a little bit visco get washed out before you do the hydrodissection. Then coming to the nucleus prolapse, the size of the rhexis should be adequate according to the density of the nucleus, and always be careful about hooking the anterior capsular margin. Do not do that. And nuclear delivery, to protect the endothelium, just make sure there is enough visco around the nucleus, and also do not irrigate before you engage the nucleus in the tunnel, because else there can be iris prolapse. And then while you're doing cortex aspiration, always be mindful of the PC and also the anterior capsular margin. And implant the IOL in a bag well inflated with visco. And dial through the main port in a clockwise direction. Main port is safe to dial. And in the bag, placement is indicated by stretch lines of the posterior capsule. And always make sure there is no wound leak before closure. If you are in doubt, put sutures. Thank you so much.
Thank you, Nilufa. That was a very good talk, and she's a very good surgeon at our place. Next, I invite Dr. Shobha for the next talk. That is a
So my talk will be on how a SICS surgeon can transform into a phaco surgeon. So as I told you, suturing is the life jacket. So, and SICS is the lifeline actually. So if you are a good SICS surgeon, becoming a phaco surgeon is not that difficult. So coming to, if you're doing a SICS, what all things you can do if you're thinking in future I have to do phaco. So one thing is temporal SICS. So many of the SICS surgeons do the SICS through superiorly or supratemporally, but sitting temporally, the anatomy and everything is a little bit different. So start to do temporal SICS if you're doing SICS, and also do a left hand side port. Left hand side port is one thing which is not in SICS but which is very important in Phaco. So do a left hand side port, and if you are more comfortable, you are doing rhexis through the main port, which is a very big 5 mm scleroconial tunnel, please do the rhexis through the side port. Try to do side port. So these all things will help you to do your future Phaco. And try to do nucleus rotation after the hydro dissection. Try to rotate the nucleus through the side port in the back. Okay. And practice bimanual IA also. So, as Dr. Niloufar also said, case selection is very, very important. Never go for very mature and too soft. Ideal is NS2 plus cataract. The central hardness is very important for the nucleus to crack. And the pupils should be well dilated, no pseudo exfoliation, and also specifically ask if in any past patient has taken any tamsulosin or anything for urinary retention, because you will have surprise on the table. The iris will be very floppy, and our cornea should be very clear. Even there should not be any endothelial pathology, and also please avoid thick carcass also. Thick carcass also dampens the view, clear view, and the AC should be deep. So the ideal case selection is also very important in planning Phaco. So, and also coming to, we will go see some step-by-steps, practice through the rhexis, practice through the side port, and also for Phacos, usually the rhexis size is smaller. It's like 5 to 5.5 because we have the good overlap of IOL to the rhexis margin is required. But in the beginning, better do a larger rhexis, because that is also helping, because if it is not working, you have to hydroprolapse or bimanually take out the nucleus when you convert to SICS. So aim for a larger rhexis. If the rhexis is small, like less than 5 millimeter, never proceed, enlarge it with Vanus or rhexis forceps or Utrata. And always calculate the rhexis size with regard to pupillary margin, pupillary dilatation, and everything. Sometimes it will be very tricky. Always calculate in mind. So in the left-hand video, you can see the pupil is very well dilated. So rhexis size is becoming a little bit on a larger side. But on the right-hand side, you can see the rhexis size is becoming on a smaller side, but in the end, surgeon is actually a little bit spiraling so that the rhexis should be adequate size. So learn the techniques like spiraling of rhexis and using the Vanus, and see, you can see now, you can see the spiraling so that the rhexis should be at least 5 mm size. So, and the next very important step is hydrodissection. Hydrodissection should be cortical cleaving hydrodissection, and we have to rotate the nucleus. Nucleus should rotate very freely in the back. Okay, so hydrodissection, we always do it through the main port, burp out a little bit visco by dipping the posterior lip of the incision, and go lift up the rhexis margin and inject the fluid. That's how you ideally do the hydrodissection. One side is, you can see the burping out of the visco and the anterior capsule. You can see the wave going. Also, make sure the hydrodissection is complete. If in doubt, repeat it on the other side. And rotate, the nucleus should rotate very freely in the back. And next is the nucleus management. So first technique which all recommend is the divide and conquer technique. So for this technique, divided corner or forequadrant. So this technique, what we need is the depth perception. We have to sculpt up to 80% of the depth of the cataract, the nucleus, and always mindful of the anatomy of the lens. It is a boat-shaped structure. So in the mid center, we have to trench a little bit deeper. In the periphery, not that deep in the center. And also we can calculate different phaco tips have different sizes. If it is like a 1 mm phaco tip, you can go like twice the size of the phaco tip. As have to see the red glow. We have many tips to know how the adequate depth has reached, like the red glow, the change in fibers, and the ease of trenching, and also the according to the size of the depth of the trench. After the trenching, dividing, we know like the instruments has to be at the bottom of the trench. So after dividing into four quadrant, it is just a piece of cake, just taking out the pieces one by one. And we have to follow certain rules, like never go to periphery, never go after pieces, be in the central 4 mm safe zone, etc. And also IOL insertion, always inflate the bag. Coming to the foldable IOLs, always inflate the bag. You can see with the visco, the bag is getting inflated. Always go to the center and inflate the bag, and then insert the IOL. So if wound assisted IOL delivery can be a little bit tricky, so we can just go with the keratome. When you go in, slightly increase the size. That will ease you for the IOL insertion. And don't try 3-piece multifocal or toric in the beginning. So, and feedback and post-ops. Find a good mentor. It is also very important. Record your surgery videos, and you have to analyze your own videos. What I can do better in next case, where why my nucleus didn't divide, what happened, and logbook, and even the OSCAR scoring system, and follow-up of cases, post-op complication, and everything is very important in phaco training. Thank you.
Thank you, Dr. Shobha. That was an excellent talk. Next, our fourth speaker is Dr. Anjana Krishnan, who will speak on entering the world of phaco. Dr. Anjana is a skilled phaco and glaucoma surgeon. Her session will focus on how young surgeons can take their first confident steps into phaco. Over to you,
Good
ma'am.
evening. At the outset, let me thank Dr. Nilofer, Dr. Jyoti, and iVision team KSOS for giving me this opportunity. As you enter the world of phaco, I think you should all be familiar with Dr. Charles Kellman, who is considered the father of phaco emulsification. He was also a musician, an entertainer, and whatnot. So the basics of phaco, I think all of you should be well read when you are starting your phaco, the fluid dynamics and all, the position, foot pedal, phaco tips available, everything should be well read and managed. Then the advantages of phaco is that we are shifting to phaco mainly because it reduces healing time, and the postoperative astigmatism is less, and the AC is more well maintained. So it has its own advantages and risks also. So patient selection has already been elaborated by Dr. Nilofer and Dr. Shobha. So an ideal patient should be around 60 to 75. It's a rough estimate. The only thing which I'd like to highlight is if it's an older patient, say 80 plus or so, if you assess it as an NS2 cataract on table, it might be NS3. And the sonules may not be as strong as you assessed on a slit lamp. So it avoids such extremes of age. And NS2 to 3 well-dilated pupils, not deep set, not shallow AC, no pseudo-exfoliation or other additional risk factors which may spoil your confidence. And the general considerations about other things like anesthesia, initially it's better to start with a peribulbar block. If you're comfortable with subtenance, you can start it. Topical you can reserve for later. The position, as already mentioned, temporal has its own advantages, but if you are a good superior SICS surgeon, you can start phaco from the superior position also. The main thing is you should be able to convert with confidence. And as already Dr. Shobha has mentioned, a scleral tunnel 1 to 2 millimeter behind the limbus in the initial stages will help rather than a clear corneal incision. The different methods of phacoemulsification are divide and conquer, stop and chop and phaco chop. And divide and conquer is the basic technique. That is the best method to start your surgery with. In this we are sculpting a groove into the nucleus and cracking it into pieces. The ideal position of the phaco probe and the second instrument is 2 clock hours away from each other. It will allow you the ease of manipulation. And the phaco power settings is usually while you are sculpting, the main aim is you have to sculpt and eat the nucleus. So the phaco power is depending upon the density of the nucleus. So it's around 20 to 60%. If NS2 to 3, you can choose according to the density of the nucleus. And the fluidics is just to maintain the anterior chamber. So you need not have a good vacuum of around 100 range, and flow rate of around 20 will help. And sculpting of the nucleus is I'm not going into the general steps while you are converting. You have already seen that. So once you are sculpting, start from the subincisional area, close to the subincisional area as possible, and this will allow you to get a longer trench. And once you are, as already mentioned, the central part is 4 millimeter, it's deeper. So you have to go accordingly. Like the center should be, you can go a little bit deeper. Then once you start seeing the red glow, you can rotate the nucleus and go for the cross trench. When after apart from the red glow, the striations of the nucleus will also help you to make out that whether you have reached adequate depth. If the striations are still seen, that means there is still matter and you can go a little more deeper. And if you feel that any of the trenches is not deep enough, you can always do a little bit more trenching in that position. For denser nucleus, you will need a wider groove. Usually one width of the phaco probe, one phaco width will be good in softer ones, but if it's a harder nucleus, 1.5 width of the phaco tip will be better. So groove through the sides, edges of the first trench, so that the overall groove will be broader. And it will allow easy cracking of the nucleus in harder ones. The cracking, as already mentioned, you have to place the instrument deep inside the groove. Then only you will get a good complete crack. If it's placed shallow, the posterior plate may not separate, and it will cause you further trouble during the next step. So this is the cracking. You have to place both the instruments side by side and just pull them apart, so that, and make sure that the pieces are fully separated when you do it. Rotate and do it on all the 4 cracks, and you get 4 separate pieces. While doing the cordon removal, the phaco power settings has to be changed. Here we have to have more holding power and more of followability. So the vacuum and the flow rate should be a bit more on the higher side, around 300 to 500 depending on the case and the phaco machine and all. And the phaco power can almost be the same depending upon the density. The technique is you can shift the position of the phaco probe a little bit laterally, so that you can get more of a hold of the pieces, bring the pieces out of the capsular bag, and phaco aspirate from the iris plane. So you can make out, bringing up into the iris plane, and then slowly aspirate it and help take the second instrument to make it into smaller pieces. Once you are done with the quadrant removal, then you have to do the irrigation and aspiration. The principle here is to engage the cortex and then strip it towards the center, and from the center aspirate it, and go on in either a clockwise or anti-clockwise manner, whichever you are comfortable. Once the cortex aspiration is complete, then you have to put the intraocular lens. Ideally fill the intraocular bag with viscoelastic. I do under saline, but it's better to go with a viscoelastic filled eye, and slowly and in a controlled manner insert the intraocular lens, and with the second instrument rotate it into place. Once you are good with your cordon removal and divide and conquer technique, then you can step ahead and go into the stop and chop technique, in which you make only the initial groove and then separate it into 2 pieces. Then you can chop each of these pieces into multiple pieces and then do as the cordon removal. Make sure at every point that you separate the pieces completely, otherwise you will end up having trouble while removing them. And once you are expert in that also, then you can try the phaco chop, in which you insert the probe into the center of the nucleus, and with a second instrument you just do the chopping and separate the pieces. Rest of the surgery is the same. Once you become good at each step, you can slowly learn the next step. So the key points to consider are: the main priority should be the patient, his vision and his general health, his comfort. You should be aware of that at every step. And whenever you are in a doubt, ask for help and learn one step at a time. Practice it, become good at it, and then go for the next one. Learn from your mistakes and others' mistakes. You can watch a lot of videos and focus on improvement, and always be ready to correct and learn. Thank you.
Thank you, Dr. Anjana, for that excellent talk. Next, we have Dr. Jyoti Anup. She is a highly accomplished phaco surgeon and refractive surgeon par excellence with more than 2 decades of surgical experience. She has surgically trained many ophthalmologists, myself included, and she has an exceptional ability to teach surgical steps. Over to you, ma'am.
Thank you, Nilufar, for that introduction. My topic is about day-to-day problems while doing phaco. So whatever Dr. Shobha and Dr. Anjana told about the problem, I'll be showing some of the problems. So in the beginning, it is very tempting to take soft cataracts, but phacoemulsification of soft cataracts are not that easy. As you can see here, I'm struggling. If you go deeper, then you may end up with a posterior capsular rent. If you go near the periphery, you may end up with a sonlar dialysis. Whereas this learning carouseling, this is a very, very good technique. You can see the phaco is finished in a minute. But you need some practice to do carouseling, and a good hydrodissection and multiple rotation of the nucleus is mandatory. Here I am still struggling with the soft cataract. So sometimes you end up with multiple problems. As this was an elderly patient, cornea is not that clear, pupil moderately dilated, he is not at all, he was not cooperative, and a hard cataract. So I decided to convert into, I started giving, I'm planning to give subtenance. Learning subtenance is a very good thing, that at any stage of your surgery, like when you do topical, you can any stage of surgery you can convert. And this is a very hard cataract. I have not emulsified deep, and my cracks are very superficial, as you can see. I haven't cracked the posterior plate. So I am struggling with the separation, and finally I ended up with an intact posterior capsule, intact posterior plate, and somehow I prolapsed a part of the nucleus and I could finish the case. So when you attempt a hard cataract in the beginning, the escape route is your rhexis. You make a large rhexis so that somehow you will escape. Otherwise, either you may end up with a sonlar dialysis or a PCR or a corneal decompensation. So when you do hard cataracts, repeated injection of visco is also mandatory. That will save your cornea. Otherwise, you will end up with severe striate keratitis next post-op. And by the time I finished this case, I had another issue. There was a conjunctival ballooning, which I managed with a small nick in the conjunctiva and squeezed out all the saline with the cotton bud, and that usually comes with a posterior location of the incision. As you can see here, I have cut the conjunctiva in the beginning. So this is another hard cataract, not very old patient, but it was hard cataract. So I have buried the nucleus well, and I could separate the posterior plate. So the phaco went on well. But here I thought I finished the case. I loaded the IOL. I'm just showing the IOL loading. And here I faced another trouble like which I have never faced in my life. My trailing haptic got stuck between the plunger and the cartridge. As I was doing a hydro insertion, I just pulled out the irrigating forceps and injected visco, and I'm cutting the cartridge. While pulling, you may break your haptic. If your haptic is broken, then you have to extend your section, explant an IOL and implant another IOL, or also you can cut the IOL inside also, but that causes severe SK, so I usually explant it by extending the section. Here I am struggling. I have removed a piece of that plastic, loosened it, still that was not coming. Finally, I pulled out this and I could escape. In such case, after this case, I took a break. Sometimes that is also essential before starting the next case. This was a simple soft cataract. I finished the phacoemulsification, but I'm trying to take out the epinucleus by taking the probe to periphery. Such overconfidence act can make you end up in major problems, like I ended up with a Sonla dialysis. I inflated the chamber with a high molecular weight viscoelastic, and I was lucky to I was able to manage it with a CTR. And when you implant a CTR, your cortex aspiration becomes really difficult. You have to pull your cortex towards the open end of the CTR. Otherwise, the cortex will never come. And this is another cataract. This is like an ideal cataract to start with an NS2, a firm nucleus. But I finished the phaco. But this firm nucleus had, I think, some firm epinucleus too. Probably my hydrodissection was not adequate, was not proper. A good hydrodissection will save a lot of your time in aspirating the cortex. I am repeating the hydrodissection here. I am rotating the epinucleus with iris repositor, and it was not coming. So what I did was a modified IOL scaffolding technique, usually done when there is a PCR. I implanted the IOL and safely emulsified the cortex. And when you do hydrodissection, that after doing a proper excis, as Nilufer told, you have to deflate your chamber a little bit. You have to express out some visco, then only you get a good hydrodissection. And you should go take your cannula towards the edge of the, even under the capsule. And then, but your hydro should be adequate. It should not be over that the nucleus may prolapse also. So this was another patient, a well-dilated pupil, but patient was on tamsulosin, and the pupil was dilated and cataract was not that hard. So I took the patient without using any devices. You can see the typical iris flutter here. This is an intraoperative floppy iris syndrome. So what I did was, I did not remove the probe at all. I completed the entire phaco with the probe inside. And the probe was kept always at the center of the pupil. otherwise you may catch some iris. And whenever there is an iris prolapse, always check the integrity of the globe, like whether the globe is hard. If your globe is hard, express out some visco or saline. And if your globe is not that hard, then you can even repose it with the high molecular weight viscoelastic. Or this is another way. Like with the iris repositor. The iris repositor, you can gently reposit the iris back. And you can, any step, if you learn iris hooks, you can use iris hook at any step of your surgery. If you have done your rhexis, then you should inject viscoelastic under the rhexis margin and the iris, otherwise you may hook your capsules. And this is, in intumescent cataracts, the most tough part in phaco is your rhexis. So whenever you do a rhexis, you should use high molecular weight viscoelastic to flatten the chamber, and you should use the forceps, either an Uttarada forceps. Here I am using an Uttarada forceps. Either use an Uttarada forceps or microforceps. Microforceps can, that is ideal, so that you can do your rhexis in an intact chamber, and you should always pull towards center. Any stage it can escape. Here I thought I finished the rhexis. It was in the last step, and this is the place where it extends, at the section where your chamber shallows. It has ran off, and I am cutting it with the vanas. As this was a soft mature cataract, and I got a very large rhexis done, and my rhexis extension was near the section, so I proceeded with the phaco. If the extension was in the opposite side, I would not have attempted that. It can cause a nuclear drop. As my first case of phaco on a rhexis escape was a nucleus drop. And while doing phaco, you should always use low flow parameters. Your wattle height has to be less, and you should not exert much pressure over the globe. So I managed it without extending. Sometimes that can extend posteriorly also. And however much ever skilled you are, sometimes that I didn't do anything. That was an Argentinian flag sign. The rhexis got torn. And this is how you should extend the rhexis, cut on either side, but I could not make it. So that was a clear corneal temporal tunnel here, and I am doing a superior SICS now. And as my rhexis was all damaged, I implanted a three-piece sensor IOL in the sulcus. Thank you.
Thank you, Dr. Jyoti, for sharing those pearls of wisdom. Your talk truly reflects the real challenges the surgeon faces once they start doing phaco regularly. It is reassuring to hear from an experienced surgeon that complications are opportunities to learn, refine technique, and improve judgment. Thank you so much. Yeah, we come to our panel discussion. Yeah. Anybody has any doubts to ask? So I have a question for Dr. Jyoti. We see a large number of ophthalmologists now starting surgical training in phaco without learning SICS at all. What are your insights on this matter, ma'am?
I already showed that you have to have a good, you have to be a good SIC surgeon to become a good phaco surgeon, because that is your escape route. Any problem you can always convert. Otherwise, you may have to do an ECC. So it is always better you learn SICS first, then go to phaco.
Thank you, ma'am. Dr. Anjana, yeah. May I ask you, at what point do you think a young surgeon who is trained in SICS can convert to, can start learning phaco?
Again, I think the answer is the same. Once you are confident in your SICS, And if you feel you can manage a little bit of complicated cases also, rather than only the well-dilated good cases, that is the point, I guess, is the right time to convert to Phaco.
May I ask Dr. Shobha, simulation-based training tools like Help Me See and IC, so these are VR virtual reality modules that are becoming popular, right? So do you think this can replace early hands-on surgical experience, or should they only complement it?
Of course, it has a place, and we have to do training like that before hands-on surgery procedures. And there are so many ways we can learn Phaco in wet lab. In one way is we can actually take the SICS nucleus and microwave it little bit and make it hard and put it in God's eye, suture the wound which we are entering, and do Phaco in the opposite side. Understand? So you will get a good chamber also. So doing practicing Phaco in wet lab or simulator is 100% very well recommended, and we have to do. And Phaco machine is very tricky actually. After some time for Jyoti madam and all, it has become a reflex. All the steps and everything, but there is always a learning curve, and the wet lab and simulators definitely have a role in Phaco practice.
Agree. Thank you so much. We come to an end of our session now. Thank you all for joining us. Thank you.